Thank you. It's my honor and privilege to introduce Shaun Michael Kunisaki on behalf of the APSA PDC Committee. Dr. Kunisaki is a skilled pediatric surgeon with an endowed professorship at the Johns Hopkins Hospital. He's a stem cell scientist with an R01-funded lab. He's the director of the fetal program and the chair of the Eastern Pediatric Surgery Network. Despite all these accolades, he remains one of the most grounded individuals I have ever known and worked with. And among his trainees at Michigan, he was infamous for flying under the radar, such that we often refer to him as the ninja surgeon. So we are very fortunate today to have him present today's first TED Talk.
Thank you, Sabina, for that very kind introduction, and good afternoon, APSA members and guests. So, very excited to talk today in our first tech talk on lung lesions. Really, the main purpose of this is really to share my personal story working in this clinical research space, and really to highlight that there's still a lot that is really unknown about this congenital anomaly. So let's get started. You can't really talk about lung lesions without acknowledging its notorious association with fetal hydrops. In 1975, so almost 50 years ago, the very first fetal lung lesion was imaged in utero by a group of physicians in Sydney, Australia. Using very primitive ultrasound technology at the time, in which they called it gray-scale echography, they diagnosed a lung lesion in a 32-week fetus that was in florid hydrops. Unfortunately, this fetus died 2 weeks later, and on autopsy, there was a giant right lower lobe lesion with adenomatoid proliferation of the terminal bronchioles, consistent with what we now refer to as a congenital pulmonary airway malformation, or CPAM. So the group at UCSF, led by Mike Harrison, as well as Scott Adzik at CHOP, really sort of delineated this field in terms of the management of these lesions early on, and noted a very high rate of in utero demise secondary to untreated hydrops. In the 1980s and 1990s, they proposed a very bold, radical, and maximally invasive procedure, that is that of fetal lobectomy. And in 2001, the cyst volume ratio, otherwise known as the CVR, was proposed at APSA as a measurement tool to be used to best identify fetuses that may actually benefit from fetal surgery. And from these studies, the cut point of 1.6 was deduced as an increased risk for hydrops. Now, for those of you who know me, I have a lot of kids. In fact, I have 7 kids. And so when I'm at home, I don't really have the opportunity to watch television unless I want to watch like Paw Patrol or Curious George. But for the rest of you, you may be familiar with Grey's Anatomy. And in fact, in season 11 of Grey's Anatomy, there was the story of Waldo Pfeiffer, who was a 23-week-old gestation fetus who had a giant CPAM, was in florid hydrops and heart failure, and underwent open fetal surgery. So just as a show of hands, how many people here in the audience saw this episode, or maybe even heard of this episode? So just a few, so I guess I'm not missing out on too much. And just another show of hands, how many people in the audience have actually been involved with a open fetal surgery case for a chest mass in their careers? Yeah, so not that many, and that's what I suspected. And the reason why is because of the fact that we now have maternal steroids. So maternal steroids were introduced by accident by the group at UCSF, Kojin Sao et al., JPS 2003. And that really has been a game changer in terms of dramatically shrinking these lesions, particularly for microcystic disease, when given before 26 weeks gestation. In addition, we have our maternal fetal medicine colleagues who are much better at placing fetal shunts for severe macrocystic disease. And so overall, what we're getting is a less severe disease phenotype of lung lesions. Moreover, because of the advancing resolution of ultrasound, as well as the more widespread use of this technology, we're now diagnosing these very small lesions that are otherwise asymptomatic, and is actually driving the incidence of congenital lung malformations up. And to our best estimates, it's about 1 in 3,000. So at the 2012 annual meeting of the Society of Maternal Fetal Medicine, our group, when I was at Michigan, presented this study entitled, "Fetal Lung Lesions, Can We Start to Breathe Easier?" This was a study that was a more contemporary look in the area of steroids. And what we found was that the rate of high drops was only 5%, and in our series, actually 85% of these patients were completely asymptomatic at birth. However, I think the most important message actually from this paper was that really for the first time, we devised and strategized that this CVR measurement actually really shouldn't be used to primarily identify patients at risk for high drops, but actually could be used to identify which fetuses might need, for example, ICU monitoring, or would be at higher risk to need neonatal surgery. Or conversely, these lesions may be so small that we could advise them that they could deliver out in their community hospitals if that was their choosing. And so based on ROC analyses, we came up with a maximum CVR of less than 1 as associated with a very low risk for neonatal pulmonary morbidity. I've pretty much been using that algorithm ever since. But don't just believe me. There are now over a dozen single-center as well as multi-center studies out there worldwide that have essentially validated this association between the CVR and neonatal morbidity. Moreover, the CVR is much more accurate in terms of specificity, and it's more quantitative than other measures such as fetal mediastinal shift. And so teaching point number 1 of this tech talk is that although we can sort of debate in terms of what this exact CVR cutoff is, the CVR is a useful predictor of neonatal outcome in this post-fetal surgery era. And obviously it has tremendous practicality in terms of prenatal counseling for your patients. So let's move on to postnatal management of lung lesions. Just as a show of hands, how many people remember first learning about these lesions, maybe in medical school, and being completely confused by the terminology of all these different lesions? I know certainly I was, okay? I mean, you have all these different types of lesions. Some of them have this weird blood supply, some of them don't. Some of them may be associated with cancer. Yeah, we're not really sure. Super confusing. Heck, even Dr. Stalker of the Stalker classification, 1977, he was so confused that at the end of his career, he actually recommended changing the nomenclature from CCAM to CPAM. So this field kind of is a mess. There are a lot of nuances to each one of these different histologies. But the bottom line is, as surgeons, we really don't have a good grasp of the natural history of these lesions, which I think is important because we're actually trying to assess the risk-benefit ratio of doing a major operation to a frightened parent who maybe even has an asymptomatic child. So I was really interested in studying this, so I proposed that to my boss at the time, Ron Herschel, that I really wanted to study this. This is going to be great. We're going to have this multi-institutional operative lung registry of lesions, and let's propose this to this fledgling organization, the Midwest Consortium. It's going to be great. And so I love Ron. There's a lot of great things about Ron, but one of the things that really is fantastic about Ron is he will research and help you research anything. I mean, if you want to research toenail fungus on ECMO, like Ron's your man, okay? So after about 3 years of working on this project, we basically published a first of many series of papers on this. And after about 500 or so lesions, we carefully delineated the different histologic types. We able to solicit a lot of opinions about the indications for surgery based on histology. And interestingly, on the lower right panel, despite the fact that we had several established fetal centers within our consortium, notice there are 0 fetal operations and really only a handful, I think 3, exit procedures in over 500 patients. The median age at prophylactic resection was about 5 months. So what are the indications, both absolute and relative indications, for operative resection? So a couple of weeks ago, I came up with this, what I think is a clever mnemonic, a CPAM. C stands for clinical, P stands for pathology suspected, A stands for age at diagnosis, and M is sort of this catch-all miscellaneous grab bag of other factors. And so at first glance, you may say, Shaun, this is kind of ridiculous. I mean, obviously, respiratory distress and infection, that's kind of a no-brainer. Of course, you would operate on this. But I would challenge you on the other side, on the right side of this slide, these relative indications, they're really controversial. Like, for example, what if you have a 3-year-old with a small lesion who comes in with a chronic dry cough? What do you do about that? What do you do about the incidental finding of a small extralobar BPS lesion? What do you do about incidentally found CLE and there's absolutely no mediastinal shift on any imaging? And probably the most common scenario, what do you do about a prenatally diagnosed CPAM? You're really excited, you get the postnatal CT scan at 2 months, and you see this little tiny ditzel, this little 0.5 centimeter, 1 centimeter lesion in the lower lobe. Are you really going to go after that? So I bet you there's people in our APSA membership who do manage these expectantly. And certainly there are many surgeons in other parts of the world, in the UK and Europe and Canada, who really more widely embrace expectant management of these lesions. It's very controversial, largely because we don't have a good handle of the natural history of some of these lesions. So teaching point number 2 is that there may be a role for expectant management of some selected lung lesions. And so the key words there are some selected lung lesions. And if you don't believe me, I'll point you to a study by Eng et al., 2014, Archives in Diseases in Childhood, where they looked at a bunch of asymptomatic prenatally diagnosed lesions, and they followed them expectantly for 5 years. And 95% of them remain completely asymptomatic after 5 years. So as a result of that, I'm currently working with APSA as well as NAFNet to try to encourage North American centers to enroll in what's called the International Congenital Lung Malformation Registry. So if your institution or you yourself are interested in enrolling patients, come see me during this meeting. These are the last 2 slides. I want to talk a little bit about pleuropulmonary blastoma, or PPB, which is an embryonal lung tumor of early childhood associated with the DICER1 mutation. There are now over 500 documented cases of PPB in an international registry. And our group looked at this through the consortium of our 177 lesions that had no evidence of antenatal detection. And what we found was that up to almost 10% of these lesions actually contain a malignancy, usually type 1 PPB. So that's pretty frightening, actually, but I think what's even more scary is that some of them were asymptomatic infants who had a preoperative CT, and the radiologists had no idea that this was possibly a malignancy in their differential diagnosis. So we actually took a deeper dive into this and decided to do a follow-up study. And in this study, what we did was we recruited 9 pediatric radiologists, all board certified, so that they weren't just like some schmoes off the street. And we said to them, hey, we got a bunch of images here. Some of them are benign, some of them are malignant. Let me know what you think about them. And so on the right here is a categorical heat map, which shows the results. The results for the 9 radiologists are shown on the x-axis. And even though these radiologists knew that the reason why we were performing this study, it was to detect malignancy, the actual sensitivity for detecting PPB by CT scan for these radiologists was only 58%. 58%, that's terrible. And so the take-home message for this, and this is teaching point number 3, is that if you have a lesion without antenatal detection that's macrocystic and does not have a systemic feeding vessel, you have to think about a malignancy, because obviously early resection is really the best chance for cure for these children. So, and these are the answers, by the way, for the two CT scans there on the left. So in the interest of time, I'll stop there. I want to thank you for your attention, and a special shout out to Dr. Kathy Van Leeuwen, as well as the Professional Development Committee, for the opportunity to present. Thank you.
We have time for a couple of questions, and then we're going to go to breakouts, and 15 minutes. The breakouts are DEI, quality, new technology, and trauma. I have a question for you. If I'm having trouble and don't exactly know what to counsel a family when I get an interesting sort of equivocal CT, can I just call you, set up a Zoom?
Sure, of course.
Awesome.
Shaun? Go ahead. I'm sorry. Max Langham, Memphis. Lights are bad. Great talk, thank you. Could you tell us what you do as far as checking Dicer mutations on children with CPAMs, particularly the small asymptomatic ones that you may want to follow?
Yeah, it's a great question, Max. So yeah, the role of Dicer-1 testing for congenital lung lesions is really undefined. What we do know is that most, but certainly not all PPB lesions carry the Dicer-1 mutation. From our best estimates, there may be up to about 25% of PPB lesions that actually won't carry the Dicer-1 mutation. Conversely, I'm not aware of any study that has ever really looked at really what the incidence of Dicer-1 positivity is in benign cystic lesions. And so we actually don't know what the background level is, but certainly if you are thinking about observing a lesion, I think it's very important to get Dicer-1 mutations testing, especially given if it's macrocystic in nature, because most of the cystic PPB is macrocystic. But that's an area that really needs to be defined, and hopefully we'll have better answers and better guidelines in terms of monitoring in the future.
Sid Johnson from University of Hawaii. Quick question on, I didn't see in your sliding scale there about what you do about a feeding vessel. And, you know, operatively, I find that a lot of them tend to be quite big, some of them almost as big as, I don't know, even the aorta. And to me, the steel phenomenon that could happen from that potentially could be a reason to remove these lesions. But it doesn't really show up as something symptomatic, but I have counseled families that way before, and I wonder your thoughts on that, whether you think that's a reasonable approach or whether you think that's even worth paying attention to.
Yeah, thanks, Sid. So is your question what to do about an extralobar sequestration and whether or not you think that's an indication to operate because of the steel phenomenon and concerns about high output cardiac failure?
Yeah, whether you think that should kind of factor into our algorithm as we approach this in counseling.
That's a great question. I mean, historically, that certainly is a phenomenon that's been described. I mean, when you have a vessel that's as large or close to the size of the aorta, I agree, I would be concerned about it. But interestingly, when you look at the adult literature on congenital lung lesions, it's a little bit slim pickings in terms of all these lesions that we had missed for generations. You know, there aren't these huge series of lesions where these unfixed bronchopulmonary sequestrations end up causing any problems. But certainly if it's large, I think it should be addressed. I mean, certainly I would recommend an intralobar sequestration, removing it anyway because of the pneumonia risk. But for the extralobar ones, if they're huge, I would recommend removing them for the reason that you discussed. But these smaller ones, I'm not really sure we know what the natural history is.